Thank you very much. Well, the task that I was given was to talk about a couple of topics to its conceptual, and I think it's setting the stage for further conversation as we'll have in the panel. So one of the topics that I was asked to address is this concept of smoldering and MGUS. And to that effect, I'm putting this graph there in the screen. I know I've talked to some of you at lunch. Some of you are dealing with a smoldering situation or an MGUS-like situation. And what I show there is how we classify things. But before I go into the details, and I hope this is pretty obvious, this is completely arbitrary. The reason we put certain cutoffs for values of the protein concentration, of the number of plasma cells, is just that when we write papers and we talk about the clinical studies, we have some common understanding of what we're going to talk about. But these boundaries are man-made. They're completely artificial. And how do they work? Well, at the extreme left, you have the MGUS, or the monoclonal gammopathy. And that is the very earliest stage we have for detection of expansion of these plasma cells, this abnormal plasma cells. And we put the boundary at 10%, because if someone has more than 10% plasma cells, then they're technically considered smoldering myeloma. And then the next boundary to active myeloma is when we have what we call end organ damage, or when someone is having complications because of the growth of the cells. And then, of course, you see in the last two stages is when the cells, they decide they can live outside of the bone marrow, they can be in the blood, they can have extramedullary presence, and that's kind of the more advanced stage of the disease. Now, this is, as I mentioned, completely arbitrary. So if you have a person who has 11% plasma cells, 12% plasma cells, are they a smoldering or an MGUS? It really doesn't matter. It's about the same as if they had 9 to 8%. And this is sometimes easier to teach than it is to live by. And what I mean by that is when we see patients in the clinic, boy, do we scratch our heads. Someone comes to us with plasma cells of 35%, and they have a very mild anemia. And we go, should we pull the trigger? Should we recommend that they start on treatment or not? Not a very easy decision to make sometimes. The extremes are very obvious. If someone comes with a high calcium with kidney damage, it's very obvious that that person needs treatment. If someone comes with a tiny protein, a perfectly normal hemoglobin, it's obvious they don't need treatment. But there's a lot of in-betweens. So this is a very, very important concept that, it's not a mathematical thing. It's not that you can do a computation that's going to tell you exactly what you need to do. We always need to look at the big picture as we see patients. Now, I'm not going to spend a lot of time. You've seen this slide already from Dr. Morgan and how we look at those proteins, and you see the M spike again. But just know when we talk about MGUS, this is a rather common condition. Dr. Robert Kyle, who is the person who started the myeloma group up in Mayo Clinic Rochester, was the one who coined this term, the MGUS. And he has established the parameters by which we understand how this affects the general population. And what he has found is, it's something that keeps going up as we go up in age. As you can see, up to 7.5% of people over the age of 85 will have an MGUS. So people can have an MGUS, and you go to the doctor, and they do some testing, and they find the monoclonal protein. And then they have a symptom, and then the next question, of course, is that symptom related to that monoclonal protein? And it may or may not be related. And that link or that connection sometimes is pretty hard in the clinic. We see a lot of those patients. Someone who has back pain, and now they have this small monoclonal protein. Is that myeloma, or is this just someone who has back pain because they have spinal stenosis, and now they have an MGUS? That determination is one of the most important things we do in the clinic, because our recommendation of whether someone should be treated or not, of course, dictates a lot of what happens down the line. So that's something we have to be very careful about. Now, what else do we consider when we talk about MGUS? So, first of all, we haven't made enough emphasis about this, and I don't know if there's anyone in the audience, but as you know, we classify the proteins into the IgG, the IgA, and the IgM. If you have an IgM, 99% chance you won't develop myeloma. 99.9% chance you won't develop myeloma. That's associated with another condition called Waldenstrom's. And that protein is usually not associated with bone destruction and the usual things for myeloma. So that's why it's critical to differentiate that from the other ones, the ones that are not IgM. Number two, there's some patients that have very low protein. So you have an M spike, less than 1.5 or the low free light chain. The risk of this progressing to myeloma is very, very low. It's estimated at 5% over 20 years. Of course, we'd like it to be 0, but it's just something that is very rare. It's unlikely to happen. And for most other patients, whether it's MGUS or smoldering, at the minimum, you should be testing for the markers on an ongoing basis, because we want to make sure that we intervene if needed before complications start. So for an MGUS patients, we say at least yearly. For smoldering multiple myeloma patients, we do that more frequently. And if you're in the audience and you're dealing with MGUS or smoldering, these are some of the red flags you should be aware of. So bone pain. Now, we all have the possibility of having pain in our joints or our bones for other reasons. The most common one, of course, with aging is stiffness, right? People wake up and it's like, it's hard and you need to warm up. The one thing that makes myeloma different from that is that myeloma pain is like the pain you would have with a fracture. So, you have a fracture, you move and it hurts a lot. You put a cast to immobilize, it doesn't hurt. So that's the pain that we worry about with myeloma. So if a person tells me, I wake up and I'm stiff, but I kind of get going, I get my coffee and I feel better, I feel, that's not myeloma. But if someone tells me I wake up and boy, I start moving and my back hurts, or at night when I press on my ribs, they hurt, that's worrisome for myeloma-associated bone disease. So that's one of the things. The second one is myeloma is almost never in the joints. It's almost always in the shafts. And myeloma rarely happens below your elbows and below your knees because we don't have a lot of bone marrow there. So again, stiff joints, not myeloma. And you all become very self-aware, of course, when you have a diagnosis like smoldering. Pain in your ribs and your back or in the shaft of the legs or weight bearing, that's concerning for myeloma. Of course, someone has fatigue or generalized weakness. We want to know about that, for instance, for anemia. Constitutional symptoms, those are things that would worry us. And I put in a list of other things. I won't go into the details, but when we see patients who have this diagnosis in the clinic, we're paying a lot of attention to all of this to see if there's anything that would raise a little red flag for us to look into further. Now, classically, you've heard about this whole thing with a CRAB criteria, which is what dictates whether we need to start treatment or not. And the acronym starts for C for calcium, A for anemia, R for renal or kidney, and B for bone. Now, they rarely happen in isolation. Usually, there's a few of them that come together when someone is progressing. And I wrote a paper a few years back that I call it the claws of the crab. And what I meant by that was as follows. So the crabs have claws and they have legs, right? But the dangerous part of the crab is the claw. And what is the dangerous part of crab for myeloma is both renal and bone disease. The reason I say that, if you have a high calcium, we have a very good chance of controlling that. That's usually not a problem. We can take care of that. If you have anemia, we can take care of that. What we don't like to see is long-lasting damage because of bone destruction, the B, or long-lasting damage to the kidneys. Now, we do have very good markers for kidney disease. The free light chain is the #1 risk factor for the kidneys being affected. If you come to Mayo Clinic, and we had a conversation about this at the table, if you come to Mayo Clinic, if you have a free light chain under 100, your risk of kidney damage is pretty low. Now, the reason I say if you come to Mayo Clinic, most other institutions use different units. They use milligrams per liter, so it would be at 1,000. So you have to look whether it's milligrams per deciliter or liter. 100 and 1,000, that's where we have the risk for kidney damage. So we pay a lot of attention to that. We don't have very good markers for prediction of who's going to get bone disease, but those are the two that worry me the most. So if I have a patient who has smoldering, don't worry too much about the calcium, don't worry about anemia, we can always fix that. If the free light chain is low, I just want to make sure I ask enough about the bones and I get the imaging studies to have some reassurance that there won't be progression to a fracture. Now, the criteria has changed recently because we realize that there's some patients who have smoldering who have a significant risk for progression in the short term. So the International Myeloma Working Group got together and decided we need to refine this a little bit further. And what was decided is that if patients have extreme smoldering situations, and what we mean by that, and I won't go into all the details, if someone has more than 60% plasma cells, if someone has an extreme abnormality on the free light chain, or if they have 2 or more lesions on their MRI, you might as well start treatment now instead of waiting for those complications to ensue. So that's something we're looking at very carefully. So this is just in a nutshell what we're thinking about with regards to smoldering and to MGUS-like situations. Now, a common question we get, and I know many of you have received treatment. Once you're in treatment, you're not back into MGUS or smoldering. MGUS and smoldering is completely reserved for those patients as a diagnostic criteria who have never seen treatment. Now, we may say you're in an MGUS-like situation, like if someone has a transplant and has a small protein, and that protein stays there forever, that's okay. It seems like an MGUS, but the diagnosis is reserved for those who have never received treatment previously. So I'm going to close that first part here. Just a few comments too as well. The second part that I was asked to address is whether myeloma can be cured or whether there is a control for multiple myeloma. And I show you this slide, and I'm just going to highlight something that Dr. Morgan has shown before, which is as time goes by, the slope of this curve changes. You can see at the beginning it's more steep, and then as time goes by, it kind of flattens out. That's true for most cancers, and that's something that we think is indicative of those patients that are 10 years out, 15 years out from treatment, and I'll show you one of those studies and how they can do very well in the long term. Now, if you were diagnosed with myeloma today, this would be some numbers that we could start thinking about. I'm going to assume, for the sake of just this example, that the person is going to go through a stem cell transplant. So, it's going to take us about 8 months to get through the induction and then to get through the transplant and get kind of recovered from transplant. So we're talking about 8 months from diagnosis. Then we're talking about another 53 months that can be projected with a survival post-stem cell transplant with a current maintenance strategy. So we're going to add 53 months there. And I'm very conservatively going to add another 36 months with the best regimens we have now for first relapse, which would be the combination of a daratumumab plus the drugs, be that pomalidomide dex or Revlimid dex or carfilzomib. And if you add this all up, we're talking about 100 months for the average patient that we're seeing a newly diagnosed. Of course, this varies. There's some patients that will have high-risk features, need other treatment sooner, and then there's some patients that will never need treatment again. And this is it. This was what was needed for treatment, stopping at the maintenance phase. So number one is this is much better, and as you can see from the curves you saw from LEAF, the prognosis keeps getting better and better. But number two is think of those 100 months as 100 months that we have right now for someone who's starting treatment for new clinical trials to develop new options to be available. So right now you're hearing about the CAR T cells, the bispecific antibodies, those antibodies that have a warhead, they're loaded, they go into the cells. So I'm sure in 100 months, the treatment will be quite different. And this is what we call the value of options. So this time, even if one faces all these treatments and you experience a relapse, you will have in time the option of being offered some of the clinical trials now as clinical tools, because they probably will be approved by then. So we want to maximize the time. So with that in mind, I often use this analogy. And again, I'm gonna talk as if we're seeing someone for the first time. A question we're asked frequently is, okay, you have a new patient, and you tell me you have 11 drugs approved since 1999. What do you do? Do you just use one drug at a time? Do you sequence? Do you keep some of your powder dry for down the line? Or do you put your best drugs right up front? So I call it the soccer versus the baseball strategy. In soccer, you don't sit your best players on game one. For those of you who follow Barcelona, if you have Messi, he plays since game number one, and you hope he's okay and safe for the final. But you play him on game one. Whereas in baseball, you can save players for down the line. Now, our colleagues in solid tumors in breast cancer, it seems like they can do okay with sequencing. So they use drug A, and then it doesn't work, and then they move to drug B, and then they move to drug C. In myeloma, every single clinical trial that's been completed tells us that we have to go more like soccer. We have to put the best foot forward right from the get-go. Now, I wish this analogy was mine, and in fact, the baseball analogy came from a patient of mine who was a fan of the Diamondbacks, so I went with him a couple of times to the stadium, and he told me once, every time you offer me a clinical trial, you give me an option. For me, it's not about winning, it's about not losing. So when you give me a clinical trial, I have more options and I have more time. And he was actually the first patient in the world to respond to carfilzomib in a phase 1 clinical trial that we had here. So he's the one who kind of showed me how to think about this analogy. Now, I'll tell you about the long term. Our Spanish colleagues published a paper that is rare that you see medical papers like this, where they say, let's look at 20 years of follow-up of a cohort of patients who are treated with stem cell transplant. Now, you already know how to interpret these curves. Now, what do the colors mean? Those that are blue were those patients that got into a complete response with transplant. Those that are red had a response, but not quite a complete response. And those that are in the tan color, the stable disease or progressive disease. And what you can see is that at 20 years, a third of those patients who were in a complete response had not progressed. Now, we see this in the clinic. I have patients who, we've monitored and we're seeing 5, 10, 15, 20 years and still remain in that complete response. So I think those are myeloma patients that are cured. But if you pay attention, you'll see some of the red ones too as well haven't progressed. So these are the patients that have the small spike and then, that just stays there, but the patient doesn't progress and doesn't require treatment again. Now, mind you, to have a 20-year follow-up duration, these patients were treated with very old regimens. They were treated with, VAD dexamethasone and sometimes even melphalan before the transplant. So we think we can do a lot better. And in this study, only 30% of the patients got into that curve. Nowadays, we probably can get twice as many, if not more, 60 to 70% of patients into a CR post-stem cell transplant with best induction and best transplant. Now, this group also this is a different data set, but now in blue, instead of showing just the CR, they show the ones that have MRD. And the MRD, of course, remains a marker for patients who are actually doing better because we have better disease control. And we still are learning about it. But what I'm going to propose to you and just answering the question with the same slide again is that, and we get into a lot of fights about this sometimes when we're in academic meetings or even in social media, there is a fraction of myeloma patients that are cured. And I say that and I discuss that when we embark on that first conversation and we think about transplant. What we need to define is what do we mean by myeloma being curable? If we mean that most patients are cured, the answer is of course not. But if we mean by that some patients can be cured, the answer is yes. And we're hoping, of course, that that answer will continue to grow and we'll see more numbers as we go into the future. And I'm sure it doesn't take a lot of imagination. You start seeing these numbers and you see these graphs and you say, well, what if we start thinking about maybe CAR T cells instead of transplant? Or maybe what if you do transplant and if you have disease, your MRD is positive post-transplant, then you do CAR T cells or you do a bispecific. What if instead of just having this 30% here on the blue curve, we're going to have now 80% because daratumumab is going to be used up front. So that's really our quest. And while we can put a lot of myeloma under control, and in fact, we sometimes do that, particularly when we can't go through the transplant and we have to put the best regimens that are possible for that person that cannot go through the transplant itself, our goal is to have everyone be in that flat part of the blue curve. That's really what we're shooting for and what Dr. Morgan and Bergsago and myself aspire with this clinical trials. And so, and just to conclude, that's what we want. And I told you about this concept of the value of options, and it's really impossible to know exactly how we're going to treat myeloma 5 years from now. So when I'm meeting with a patient and they tell me, okay, what do I expect? What's my future? The answer is we don't know. And we simply don't know because what we're seeing is there's more tools and there's more options. And of course, we want this to translate into better regimens. And I wish the reality was for cure for everyone today with a week of treatment that costs nothing and has no toxicity, right? And in fact, makes you stronger. But we're not there yet. but we're making a lot of progress. So thank you for your attention again.